Welcome back. Sorry about that short break, but we want to make sure we're on schedule for everyone's time. The next session is access to care versus access to quality care. It will be moderated by Dr. Brett Anderson. Dr. Anderson is a pediatric cardiologist and National Institutes of Health researcher. She blends her medical, business, and statistical backgrounds to study quality and value associated with the management of pediatric heart disease. Dr. Anderson is also the current vice chair of Conquering CHD's Scientific Advisory Committee. Please join me in welcoming Dr. Anderson, who will introduce the panelists.
Thank you very much. I'm grateful to Conquering CHD to have the opportunity to be with you all here today and to introduce our next group of speakers. So for the next session, our panelists will delve into discussions not only on access to care, but also access to quality of care. Our panelists have some very unique perspectives on this topic, and I'm excited to introduce them here. So Dr. Joseph Burns is a resident in pediatrics at Cohen Children's Medical Center in Queens, New York, and the founder of the Collaborative of Pediatric American Indian Medical Trainees. Dr. Burns is also a patient living with CHD. Dr. Burns is an active advocate for Conquering CHD and has focused his research on patient advocacy projects. He'll share with us some of the challenges facing Native American child health, including a discussion of the Indian Child Welfare Act. Ms. Carol Raimondi is a former nurse and an adult living with Conquering CHD. She's an active volunteer with Conquering CHD Illinois, as well as a seasoned advocate at the national level. Ms. Raimondi will share with us today her experiences in accessing quality adult congenital care and some of the tolls that this took on her and her family and how she navigated these challenges. Our next speaker will be Dr. Elijah Bolin. He's a pediatric cardiologist and associate professor at Arkansas Children's Hospital. He specializes in fetal echocardiography and fetal diagnosis, and will discuss with us access to prenatal care and some of the work that he and his colleagues have undertaken to expand access to prenatal care across Arkansas. I apologize, I'm going back and forth on these slides. I adjusted them a little as we thought through some of the ways in which we want to talk through these topics today. So our next speaker is also going to be Dr. Shab Pavandia. Dr. Pavandia is a pediatric cardiologist and associate professor at UCSF Banhoff Children's Hospital in San Francisco, California. She's the co-director of Healthy Hearts and Minds program, expanding neurodevelopmental access across California for patients with congenital heart disease. Dr. Pavandia will discuss with us some of the challenges associated with access to neurodevelopmental care and the work that she has spearheaded in California. And then finally, we'll talk again with Dr. Ram Subramanian. We met Dr. Subramanian earlier today. He's a cardiothoracic surgeon, assistant professor at Children's Hospital, Los Angeles, and the current chair of our Scientific Advisory Committee. Dr. Subramanian has been an avid researcher and vocal advocate for access to quality surgical care for children with congenital heart disease, and will lend to this conversation his perspectives on the surgical space. So I'm going to start our conversation with Dr. Burns. When we talk about health disparities and access to care, we often focus much of our conversation in the United States on issues affecting Black and Latino communities. Dr. Burns, you have a very interesting perspective as a Native American, as someone who yourself has congenital heart disease, and as someone deeply integrated into advocacy for Native American child health rights. I was wondering if you could start us off by talking about some of the challenges facing Native American children as they seek to access pediatric care.
Of course. Dr. Anderson, thank you for the introduction, and thank you to Conquering CHD for the opportunity to join such an esteemed panel. It's impossible to discuss Native American child health outcomes without considering the role of access to care. And perhaps in no population, rather than any other, is access to care so dictated by federal policy. Access to care for American Indian and Alaska Native children and adults is extremely closely tied to land allocation patterns. For federally recognized tribes, care is primarily delivered through one of three methods, either through the Indian Health Service, tribally operated health organizations, or urban Indian health organizations. Generally, we refer to this as ITU, just broadly speaking. In 2014, the population eligible for Indian health care services numbered 2.1 million. And of these, 31% were under age 15. Funding for each method varies considerably, ranging from federal allocation in IHS sites to tribally funded medical clinics. And so it's important to note that the IHS has the lowest per capita funding of any federal healthcare program, including federal prisons. And so this often leads to gaps in care for Alaska Native and American Indian populations receiving care across these ITU settings. For example, because federal allocations for the IHS often shift with changes in political priority, IHS funded sites may receive less resources or funds, and it's difficult to predict the amount they may receive. Those that are allocated may be directed towards programs or services that communities don't necessarily see as a priority. So this is to say there's often a disconnect in the federal agenda and that of the communities actually being served. On the other hand, a tribally run health facility may be able to decide what funds are allocated where, but may have difficulty developing the funds to do so. And this is especially true in scenarios where tribes are not affiliated with a large income producing enterprise like casinos or tobacco. However, approximately 70% of the American Indian population in the United States lives in urban areas, with 25% living in counties served by urban Indian health programs. So currently there are 42 centers receiving grants and contracts through the IHS to be designated as one of these sites. Of these, only 21 are full ambulatory care centers, leaving a majority of individuals unable to access proper care. And this is further complicated by a lack of insurance in the urban American Indian population, as there are more uninsured American Indian individuals relative to the non-Hispanic white populations in these same areas. Even so, individuals living in urban settings may be able to access care from medical systems outside of this ITU designation. But on the other hand, individuals living in rural or reservation settings are faced with additional barriers to care, including limited number of care facilities, far proximity from centers, and lack of transportation options. Land allocation and the location of IHS and tribal health centers in remote and rural areas also significantly impact the recruitment of qualified physicians for roles within the Indian Health Service. Vacancy rates range from 13 to 31%, and an average of 25% across all health professions, including physicians, nurses, PAs, midwives, dentists, and pharmacists. And hiring and retention are an issue in part due to salary deficits, which are especially problematic for healthcare providers who accrued significant debt in their training years. But adequate housing close to work and lack of opportunities for spouses, poor educational opportunities for their children, and location largely in food deserts are also barriers to acquiring longer term service among IHS employees. So in this way, there's a clear overlap between land allocation and access to care for these communities, alongside with provider shortages, which ultimately contribute to adverse health outcomes. So it's clear that there's a strong association between federal policy and the way that care is implemented in these populations. One such win, however, was the implementation of the Indian Child Welfare Act. This 1978 act was a response to a crisis affecting a large number of American Indian and Alaska Native children, families, and tribes. This is to say that there's a significant body of literature that substantiates that large numbers of Native children were being separated from their families and extended families through private adoption agencies. This act stipulates that when possible, to remain within the family or to remain within the tribe is optimal to promote health outcomes in these children. So the ICWA or ICWA, the Indian Child Welfare Act, stipulates that by providing active efforts to keep the child within the family, identifying a placement that fits under preferred provisions, meaning largely within the culture, or notifying the tribe and the child's parents of custody proceedings, and working actively to involve the tribe and the child's parents in the proceedings, we may be able to keep these children within the community. Again, this is since 1978, but it gets reallocated every 4 years. So it's an issue that requires constant attention in order to protect this vulnerable population. And as this is a preface to an advocacy conference, I think it goes without saying that it's important to consider the health of Native American and Alaska Native children, specifically through providing support for the Indian Health Service and considering the Indian Health Service Advanced Appropriations Act, generally just trying to increase the bucket of money that gets allocated to these populations and hopefully improving their own discretion to dictate where this money goes. So again, this is a population that often is kind of left out of these conversations, but provides us with a nice basis for a jumping off point in this own conversation about access to care and access to quality care.
Thank you, Dr. Burns. That was, I think, a lot of information that many of us may not have been fully aware of. And as you mentioned, this act is coming up for renewal again. And one of the things to think about is there are not a lot of pediatric cardiologists and even fewer adult congenital providers within IHS. And what are some of the things that providers hearing this talk can do or start to think about to expand their outreach for these communities?
Sure. So one of the greatest challenges exists in considering the immense land mass that encompass reservation lands and the distance to major centers. One such success is through the partnership with the Alaska branch of the Indian Health Service and Seattle Children's Hospital. In this relationship, these children are able to connect with providers in Seattle, be it virtually or through transportation coordinated by the center, to try and improve access to care in this way. Of course, telemedicine has become a more important part of this conversation, especially in the time of COVID-19, but it's not without its limitations, particularly within this population, given the lack of smart device access, reliable internet connection, and other social barriers to care. However, this is certainly an evolving modality, particularly within the world of congenital heart disease, as we'll hear in the conversation to come. And surely there's still a lot of work to be done to improve access to care for this population.
Thank you. That's very enlightening. I think that as we move on in our conversation, we start talking about what some of the other providers in this group have done in terms of using smart technologies to reach out to rural communities. I think this there may be some interesting ways in which we can all think about moving this forward. I want to pivot for a second to Ms. Raimondi. So Ms. Raimondi, you grew up and transitioned to adult care in Chicago, which is certainly not a healthcare desert by any stretch of the imagination. And yet you also faced some barriers to accessing adult congenital care. We had the pleasure of having you share with us a little bit about this story. I wonder if you could share with the audience about the challenges that you and your family faced going through this transition.
Of course. Thank you for having me, first of all. Pleasure to be on this committee with everyone in this panel. As you mentioned, I was born with congenital heart defects here in just outside of Chicago. I had very complex congenital heart defects. I have LTGA, and I had an atrial septal defect, ventricular septal defect, pulmonary stenosis, and dextrocardia. And all of my care was at one of the larger institutions at the time here in the city. And I had my first couple open heart surgeries there with my pediatric cardiologist, pediatric surgeon, and everything was going smoothly. When I was about 20 years old, it was time for me to have my third open heart surgery. And I had, at the time, there really wasn't any adult congenital cardiologists. It was, over 20 years ago, they were very fewer and far between than they are now. And I went to a regular general cardiologist who, felt that he could handle my care. And it did come to be that I needed to have another open heart surgery. And my pediatric cardiac surgeon was no longer at that facility. So I was referred to one of the cardiac surgeons on staff there who, was supposed to be top notch, one of the best surgeons they had, cover of, Top Doctor, Chicago Magazine. So, you go into this feeling this trust. And the surgery I had was to replace a pulmonary conduit. And the surgery itself lasted 13 hours, which, it was a third open heart surgery. It was not completely unexpected, but I remember my husband, and my mom telling me that after he finished surgery, the first thing he said to them, not that, that I was doing okay, but it was that he would never touch me again. And it just goes to show that I had a very rough, long journey after that surgery with a lot of complications, including an osteomyelitis. I had a sternal wound infection that turned into an osteomyelitis, which followed with a sepsis from one of the central lines, and ended up in endocarditis. So it was a very rough postoperative course. And I attribute this now in retrospect to the lack of knowledge that this surgeon had regarding my defect. And fast forward about almost 10 years, I had to go on medical disability, stop nursing due to worsening heart failure. And I was being seen by an adult congenital cardiologist in the Chicago area, who, I felt that I was at a center, it was a different center, that had the surgeons that should have been able to do my surgery. And it was going to be more extensive a surgery than the previous. And I was told that they felt my case was too complex to handle there. So I was referred to Mayo Clinic. Now, Mayo Clinic is about a 6-hour drive from our home here in Chicago. By the time I got referred and got up there to get that proper care, the surgeon and cardiologist up there said that I should have been there 6 months before because my heart function had gotten so bad. So the surgery was done up there by an adult congenital surgeon who did many, many surgeries throughout the year on adult patients and was much more familiar with my anatomy compared to the last surgeon. And he also replaced my pulmonary conduit as the last one did, but also did a tricuspid valve replacement and a pulmonary valve replacement, a mitral valve repair. And the difference was that surgery took 6 hours compared to the 13 from the previous, with obviously doing much more work. And my postoperative course was very smooth. It was a night and day difference. And I realized, looking back, like how much of a difference it made having that quality care, which unfortunately was 6 hours away. And I continued my care at Mayo Clinic following that. And even though I knew I was getting the best care, the best quality care from my case, it was requiring my husband to take, several days off of work. It was a financial burden because we had to pay for gas and lodging and food. And a lot of times we would be told, oh, we're up there. Well, we want you to do this test while you're here, but it'll be like, we can't do it for like 2 more days. And I feel like a lot of times it was just, it was just, they didn't think about that, like the implications that took on us. Whereas, that involved having my husband take more time off, my daughter off of school if she was, in school at the time. So, and even in my follow-up care with them, if I was having an issue, they'd say, well, you know what, why don't we get you up here to see you in a couple of weeks? And it wasn't that easy. So it was definitely, even though I felt like I was definitely in the right care, it was so much harder because of the distance. When I had that surgery, it was hard to have a lot of family come up there because of that. And now, fortunately, I am found a great adult congenital provider in the Chicago area who a couple of years ago appropriately referred me to the hospital they partner with for adult congenital care, actually to their advanced heart failure team, where I've been listed for transplant and currently have a ventricular assist device. So it's living in Chicago, you would never have thought that I would have had an issue getting care. And unfortunately, I found out the hard way that there's a huge difference between just having lots of options versus the correct ones.
Thank you, Mr. Mondi, for sharing that experience with us. And I'm sure we can all appreciate that this is a painful story for you to tell in a lot of ways. And unfortunately, it's not unique. There were some obvious trade-offs that you and your family chose to make. And you were fortunate enough to be able to make those. And yet also it sounds like there's some regret about not knowing to make them sooner. Go ahead.
Oh, I was just going to say absolutely. And, it obviously affected my care, my outcome of that surgery, and which has had, long-term implications with scar tissue and such.
It is, there are people like Dr. Subramanian who've spent a lot of time thinking about this question of what has been referred to as regionalization of care. Which centers should be providing what care? How far are we making patients travel for care? Talk, if you wouldn't mind, Ms. Raimondi, a little bit about decisions that you made to bring your care back to Chicago, and what allowed you to do that. Because I think that's where it feels like when you went up to Mayo, there was no option. You had to go, despite the toll it took on you. But you did make that decision to come back. Do you mind sharing with us about that choice?
Sure. I, because of the toll it was taking, like it became, when we decided to do family getaways, it was always associated with a trip to Mayo. Like, hey, let's spend a day in the Dells, like halfway up there, Wisconsin Dells, halfway up there. And, we felt like, okay, this isn't fun because it's still associated with going to the doctor and testing and whatnot. But then I was told about some programs that were opening up in Chicago where they were getting more physicians. And I felt like it was important to have somebody local in case the issues came up that I needed to have taken care of urgently. So there was a program at the hospital that I really said I would never go back to, but I kind of took a leap of faith. And my first question was if that surgeon was still there. And she said, who? And I said, okay, we're good. And so it was great for about a year, but then unfortunately, a lot of these ACHD physicians go, they come and go. And this doctor left to go out of state to a different hospital, and the whole program kind of crumbled behind it. And it was unfortunate because I again felt like I was lost. Like, okay, do I have to always continue going up to Mayo for every, twice a year? And then it was finally, a few years ago where I was told, my internist was very insistent on, like, there's more adult congenital cardiologists in the area now. And again, you're in Chicago, but we have probably 2 or 3 hospitals that really have, bigger programs, but bigger still means only 2 doctors. I mean, that's not still, a considerably large program. So I did end up going back to that one on her recommendation, just again, to have somebody local if something came up, because we did have a problem. I had a very high potassium level, and they were trying to get in touch with my my team at Mayo Clinic here at my primary doctor at my local hospital, and they couldn't get a hold of them. And it was very difficult because they didn't know, like, if they had to do dialysis to bring down these levels, and they didn't really have direction. So I was really pushed to see one of these cardiologists in the Chicago area, one of the adult congenital cardiologists. And so I took that leap of faith yet again. And I was very fortunate because I felt like the doctor I saw was very thorough. She was very knowledgeable about my condition. And I felt that I was in good care. And when she referred me to the advanced heart failure team, she referred me to one of the doctors who handles a lot of her adult congenital patients, and they work together. So it was very hard putting that trust back into these systems that kind of pushed me away or disappointed me in the past. But honestly, it was nice because, before I got listed for transplant, we said, hey, let's take a trip, and it doesn't have to be to, centered around a doctor's appointment. And it almost felt like something, felt normal. So I have to say I'm grateful, but unfortunately, like I said, these doctors, still the doctor that I saw has now since moved on. So it's frustrating because that continuity of care isn't there always.
Thank you. I think that continuity of care often becomes a challenge. And you're right, there's been a lot of movement within the adult congenital space and among the surgical space. And we all know that our patients get attached to their cardiologists, they get attached to their surgeons as well. I want to pivot for a second to the other end of the care spectrum and think about this distance to care. Dr. Bolin, you and your team have spent a lot of time thinking about distance to care on the prenatal diagnosis side and have taken some very unique approaches to tackling this and of bringing care to patients rather than patients to care. Wondering if you could tell us a little bit about what has been done down in Arkansas and what the rest of us might learn from this.
Yeah, thank you so much, Brett, and thank you all for inviting me here today. So, yeah, as Brett said, I'm here at Arkansas Children's in Little Rock, Arkansas, right in the middle of the state. We serve everybody in the state, so 3 million people in the state of Arkansas. We're the only children's hospital here, and our state has one of the highest rates of rurality in the United States. So we have a lot of people living outside of urban areas. And we're the second poorest state as well, based on median household income. So there are a lot of barriers to providing care for children with congenital heart disease here in Arkansas. And one of the things that we established here was a telemedicine program, which had several prongs to it. The one that I was most involved with was the Fetal Telemedicine program. And we think it's been pretty successful. We started it a little over 10 years ago, actually before I came here. And I've been here for 6 years now. And we positioned 6 telemedicine centers across the state where we did telehealth with pregnant mothers who were at risk of having a child with congenital heart disease. And we identified babies with congenital heart disease, and we actually did video conferencing as well. So and our rates of diagnosis of a prenatal diagnosis of congenital heart disease, of critical congenital heart disease, that is congenital heart disease identified as being prostaglandin dependent by the Society of Thoracic Surgeons, went from, it was abysmal, it was in the teens, and it went to the national average, even just a little bit above the national average amongst states. It was over 50% now. Now, there's a lot of other things that happened in that time period that you could ascribe to our success, but I do think it was in part due to, and we've done some looking into the data and published that about how that those numbers actually came up probably because of this program that we initiated. Some other prongs to our telemedicine programs as well, but that's one, and I know that telemedicine had already been mentioned here. That's one thing in terms of tackling, this rurality problem. It's not an end-all solution. There's a lot of things that you got to do hands-on as a pediatric cardiologist and obviously as a congenital heart surgeon, but it has helped us in our state here.
So tell us this, right? So telemedicine has a lot of different meanings in a lot of different spaces, right? There's the CVS approach. You go in and you get your vitals on some little handheld device and it beams it off to some faraway location. There's telestroke, where they're, doing CT scans of your head while you're riding in an ambulance. How are you doing telemedicine, fetal echoes? I mean, we just talked about how you really need a congenital heart surgeon doing congenital heart surgery. Not just anyone can go do a congenital echo. So what were you doing?
We had a fantastic sonographer who is willing to get in her car and drive to all ends of the state. And you got to have buy-in, and you got to be able to pay for that, you know? And so it did cut down on the amount of work, and obviously it cut down on the amount of work that parents had to do, because it was one sonographer versus lots of families driving into Central Arkansas. But we still had to have that sonographer traveling, because you can't, I mean, with fetal echo, as you all know, it doesn't work if it's a general OB sonographer doing it. And so we needed somebody with formal fetal echo training that we trusted. I had to trust her, I mean, just as much as I could trust myself doing a fetal echo. And so we had that. And that's something unique to our program. And I know Bettina Cuneo in Colorado, and there's been some other descriptions of telemedicine programs with a little bit different flavors than ours, but all of them have that same that same fundamental portion of it, that you have to have somebody who knows what they're doing on the echo end of things, on the ultrasound end of things.
Can I ask a question? So that's wonderful, Elijah, and so exciting. I'm also a fetal cardiologist, and I think part of the reason why there's so much missed diagnoses prenatally is because the heart disease is not picked up on the screening ultrasound that's performed by the obstetrician, and then the referral is not made to the fetal cardiologist. But I wonder if in your case in Arkansas that the referral patterns changed because now there's someone more locally available to perform the fetal echocardiogram. So there was less, they were more likely to refer. Like if they were slightly unsure about something, they knew somebody was going to be there to do the fetal echo next week. So they were more likely to refer versus saying, I think it's normal, let's just move on.
Chab, I think that's an excellent point. And actually that's something that we should probably look into as well. We have the advantage here of being the central, the only providers of congenital heart care. And we have an active congenital anomalies surveillance system. And actually that question we could answer, probably answer academically. And that's a great angle on it. I'm actually going to bring that to somebody else, and that's a great fellow project maybe. But thank you. Yeah, it's a great question. I mean, even physicians out there, general OBs, knowing that that kind of care is out there increases the referral patterns. And the same actually I think goes true for us doing transthoracic teleechocardiograms, which kind of serve in a big state. They kind of serve as a cheap consult. I mean, again, it's nowhere near like having your hands on a child and listening to their heart, but it's a lot better than having no data.
That's great. Maybe Dr. Pivande, if we can pivot to you and have you tell about some of the outreach programs you guys have done in California, and thinking about bringing access to of care across your state.
Yeah, sure. So thanks everybody, and thank you Conquering CHD for inviting me to be a part of this panel. It's really wonderful to hear everyone's stories and what everyone's doing to increase access to quality care. So in my role, I started our neurodevelopmental follow-up program here at UCSF Benioff Children's Hospital. And when I first started, not a lot of our children with congenital heart disease were getting follow-up developmental care. And we know that, some children can have some difficulties with developmental outcomes, not all, but some can. And so the important part is that is to provide developmental screening so that if there is an issue, there's early recognition and early intervention, because you could optimize those outcomes and they end up doing okay. And so where we are in California, we serve pretty much a pretty big area from Central California all the way up to the Oregon border. So we have patients coming from all over the place. And I think one part of the discussion that's important is access to quality surgical and perioperative care. But the other part is access to long-term follow-up care and what happens after the patient is discharged home to their community. Where are they getting their cardiology, outpatient visits, as well as some of these ancillary services, including developmental screening. So we took a sort of a two-pronged approach here to try to increase rates of developmental screening among children with congenital heart disease. One approach was sort of an educational approach of educating providers, but I think more importantly, educating families and empowering families to know that this service exists. And there's really no greater advocate for the child than their mother and father and their family. And what we started doing is upon discharge from the neonatal hospitalization, somebody from our team would go talk to the family about the importance of developmental screening, developmental care. And sometimes these children were going back to their home institutions that had their own developmental screening programs, but the connection just wasn't being made that they were receiving that care once they went back to their home institution. So by empowering the families to ask about it when they went to their home institution and to see their pediatrician or their cardiologist, as well as sending a discharge summary to the developmental screening program at their home institution, really allowed for increased rates of developmental screening for that child. The second part of that approach was similar to when we talk about access to care. Instead of expecting all of these patients to come back to our urban medical centers, is taking this care to those communities so that we're not expecting families to drive several hours, pay ridiculous parking rates, take a lot of time off of work, as we heard from Ms. Raimondi, which can be very challenging for families. So we partnered with our neonatal follow-up program, and I have to say the NICU people and the people who take care of premature babies and their follow-up programs for developmental care are very mature, and they've done a fantastic job in California of having outreach sites. And so we partnered with that group to allow for our children with congenital heart disease in these different communities to also get that developmental care. And, you know, not surprisingly, it does take some financial resources to accommodate that, in terms of we needed extra personnel and things to accommodate these children. But I think both those approaches really did lead to an increase in rates of developmental screening among our patients leaving the hospital.
I think that's so important that we're doing that. I mean, I think that for a long time we focused on surviving congenital heart disease, and now we're really needing to focus on thriving with congenital heart disease, and neurodevelopmental outcomes is a very large and important part of that. I want to pivot to Dr. Subramanian, and don't worry, I am not going to ask you about how you are expanding remote robotic congenital heart surgery. But I am curious to get your reactions to this conversation as you think about expanding access to surgical care beyond, major cities. What are your responses to this, and what can the surgical community do?
Yeah, you're asking a great question, Brett, and Shab touched upon some excellent concepts that are unique to California. And it's funny that it came right following Elijah's statement that they are the only only cardiac program for the entire state. So I'm going to start and end that conversation with that discrepancy. Clearly, we're doing something wrong, right? We have a state like Arkansas with one program, and around us in Los Angeles, there are 4 programs within a 20-mile radius. We're doing something wrong. I think this requires an advocacy level input. Again, a plug for today's conference, for tomorrow's conference. This requires an intervention for all of us stakeholders to be able to move in and make a difference. So what do I propose is the best way to expand surgical care? And when I say surgical care, I'm going to go back to what Shab said. Surgical care starts with good fetal prenatal diagnosis, with good preoperative care and outstanding post-surgical follow-up. It's not just a physical act of cutting, sewing, and recovering from the ICU. Everything put together. What can we do differently? People keep asking me, who's your nearest competition to where you are in Southern California in congenital cardiac surgery? Who's your nearest competition? And I answer them the same way. My competition is congenital heart disease. That's my enemy. All of us are on the same side of the battle. So we go to a in my opinion, a spoke and hub, spokes of a wheel tiered model system. It's one of the many options that are available, but we could consider something like that. What do I mean by that? We have a tiered system whereby, like Shab and like Elijah was saying, there are some things that can be provided close to home. There are some things for which they will need to go to a very super specialized centers. And these can relatively easily be tiered. You could provide remote screening prenatal echocardiography, but if the defect happens to be something that is a little complicated, or like Elijah mentioned, it's going to be PGE dependent, well, then let's bring you into a center, discuss what's the best way to work around having you deliver in a center that can provide immediate postnatal care, intubation, PGE, transfer to a neonatal or a cardiac ICU. Let's talk about that. All right. If we're talking about a VSD repair, like your title rightly says, all we need to do is, for a relatively common low mortality operation, is identify a safe center. Do I need to, travel 600 miles to go get an ASD closed? Or would I compromise on very high complexity operation like a neonatal complex transposition or a hypoplast repair? So that way we can tier out. We can say some of these procedures can be safely done in certain centers. Some of the procedures need to be done in centers with higher volume, like Carol so beautifully put together. And again, this could be expanded to outreach areas where we may not have direct access. Going back to what Joseph was saying, we, like Shab was mentioning, have a relationship with Guam, where we're able to remotely read their echocardiograms. That provides the majority screening. We have a mechanism by which patients can fly commercial airline if it's an elective operation. And if they're very sick, we fly and bring them with the most advanced medical transportation system. This kind of a tiered care, I think, is important, not just to improve referral, like Shab mentioned, but also to improve compliance. Maybe there's something wrong with your fetus. Are you willing to travel, 200 miles and lose your day's wages? Or could I just do a remote job today where it takes you 15 minutes and then I can triage you and then say, you need to go or you don't need to go? To me, that's the best way to improve access to surgical care.
I'd like to hear Ms. Ramondi's response to that as a patient, because I think that this is something, Dr. Subramanian, you and I have spoken on this at length, and we're aligned. This seems like a great idea to us. But how do you react being told, yes, we think we're good enough to handle this, but not that? And what if you're the good enough to population? Do you feel comfortable staying?
Yeah, and I think, again, that depends on the level of severity of or complexity of your disease. Knowing what I do now with my experience, would it be nice? And there was a short time where they did have a echo tech come down to the Chicagoland area from Mayo once a month. And they would be able to do an echo on me and show it to the doctor, send it to the doctors up there, or even sometimes one of the cardiologists would come down. Not always necessarily the one, it was never my specific cardiologist, but one that was familiar with me, to do an echo. And that was a great opportunity because you have that quality care coming to you. Instead of having to make that drive. And again, like you had pointed out, we want to have that right doctor and is good enough. What's the value of good enough to you? For me, I've learned the hard way that no, I want who really knows me, because I thought I had good enough. I thought I had, this doctor knows that this is what's wrong with my heart. And this doctor says, yeah, I can fix it, no problem. And the outcome was not great, and I learned from that experience, like, I'm not going to accept just good enough. And that's what made the, decision easier to have to make those sacrifices to travel, 6 hours and take several days off of, work and whatnot. But it was definitely not an easy decision just because of the impact it would have on our family. But I think had I not had that experience, I probably would have done the same thing though. I would have said, well, they say they're adult congenital, cardiologist. So, and I did see one that's, there's a big difference to saying that you are adult congenital cardiologist versus, yeah, I have an interest in it. I've looked at, I think it's interesting to me. And I think that's another issue that comes up is that experience, because like somebody referred to earlier today, those general cardiologists only have 6 hours of congenital training, and adult congenital is still another whole ball of wax. And I definitely feel like, knowing what I do now, like I would make those sacrifices again. I don't know if that is that. I hope that answers.
No, I think that's very helpful. And, I think that there's no one answer, right? There is no one size fits all. Every person and every family is going to be different. And every situation is different. And I think it's helpful. I am sure that there are many in the audience who have struggled for themselves and their families to deal with this. And I think it's helpful to hear how other people have thought through that. We've gotten several questions in the audience about insurance. And, it is one thing when you have no provider in your state, and therefore you are able to cross state lines. It is another thing when even those of us within the field might think you have no provider in your state, but technically you do. And insurance may be more hesitant. We're similarly getting questions from the audience about neurodevelopmental follow-up. That there are several people in the audience who say that within their state, they're not paying for it. They're curious about if in California it's getting paid for. I can either Dr. Bhavani or Dr. Subramanian, either of you want to tackle this question of the interplay between insurance and access, and how you have dealt with that. We will start with the neurodevelopmental question. Is California paying for neurodevelopmental follow-up? Is there room for conquering CHD in this advocacy space? What do we need to do to push on insurance here?
So I think it is state dependent, unfortunately. And so in California, yes, if you're on Medicaid or CCS, which is California Children's Services, they do pay for neurodevelopmental follow-up for patients, including in infancy, as well as when they sort of graduate, and we provide early childhood or care in adolescence. So we're sort of lucky in that sense here in California, but I do know that that is not the case in other states. And so organizations like Conquering CHD, I think would be fantastic to advocate for this patient population and change some of those policies in states where Medicaid is not covered for this. It would seem for this, it should be pretty routine, but I wonder if in those states, if things like prematurity do lead to coverage for developmental screening, then it shouldn't be very difficult to make the case for congenital heart disease as well.
Yeah, thank you. I agree with Dr. Pavandi on this. She's making a very good point. I think advocacy is important at a national level, because now it's almost like, unlike Medicare, Medicaid has become very state specific. And I think advocacy at a national level is required to set some minimum standards. And that's also important if anybody was going to go through this tiered model, because we need to incentivize institutions that may be considered the so-called you're good enough. There's no such thing called it's not good enough or better enough or even betterer. It's none of those words. It's a partnership. There is fantastic experience. There is very good evidence that it can be done. Cincinnati and UK, University of Kentucky, it's a very good example that immediately comes to mind. Mayo and Minnesota Children's is another excellent example. There is evidence that this can be managed appropriately. The question becomes, who's going to do it? And as a physician, as a practitioner, I can tell you, not even the last person to do it should be the insurance provider. People that should do it is all the other stakeholders, but the insurance provider. That includes us, that includes families, that includes parents, that includes Conquering CHD. Hence, go for it tomorrow. I mean, this needs to be law. People need to make this kind of a option available to all of us as stakeholders.
Dr. Bolin, in Arkansas, things like neurodevelopmental follow-up, are they covered? I know you talked about how Arkansas actually expanded Medicaid. Actually, you talked with me about it. I don't know if we've talked about it yet on this call. They were one of the states that did in fact go through Medicaid expansion, and how that has improved care. Has that impacted neurodevelopmental care, and what are you seeing there?
Yeah. So yeah, thank you for asking that. So we weren't just a state that adopted Medicaid and the Affordable Care Act. We are a red state that adopted the Affordable Care Act. So props to us. And it has benefited our children and how they get their care paid for, and that expansion has applied to neurodevelopmental follow-up as well. I'll tell you the big wrinkle in all of this that we're fighting right now is about closing borders for Medicaid, because Medicaid, as Ram was saying, is adjudicated by the states largely. And so there are states around us that have closed, like children aren't allowed to come to us or go to other states for their care. It's like, oh, well, there's a congenital center there, you have to get your care there. And families can't make those decisions. And I'm against that. I mean, for a lot of reasons, but one of them is if you just think about like a child living in West Memphis, which is technically in Arkansas, across the Mississippi River, they would have to come to Little Rock to get their care. And that doesn't make any sense. And so this is stuff for the families out there that are listening in. Like you don't want your state to close its borders on Medicaid. Okay. And if they have, talk to your elected representatives about this. This is not something that's going to benefit the children of your state in the end.
I have to say, we've seen the same thing in New York. A lot of our providers actually live right over the George Washington Bridge within, in New Jersey, within sight of our hospital. And yet the patients within that state cannot, without great pains, come the half a mile across the river to come see us, because the Hudson River calls a state line, and, ne'er shall one pass. As we're thinking about Medicaid, I want to pivot back to Dr. Burns and things you were talking about with Native American children and accessing care. And think about, where there are barriers for them getting outside of reservations, and are there ways we can include them into this conversation and make this part of one inclusive conversation instead of two separate ones? Do you have any thoughts on that?
Yeah, thank you. So it is true that federally registered individuals are entitled to access to care through the Indian Health Service. And as we've discussed, that it is in both Indian Health Service facilities, which are largely on reservations in larger metropolitan areas, plus these urban health centers and tribally designated facilities. However, that's a lot of, and if we think about a Swiss cheese model, there are tons of holes for federally registered individuals to fall through and end up with inadequate access to care. So this is to say, like, increasing the number of the facilities or facilities in which this type of coverage is accepted would be instrumental in improving access to care. And there's work actively being done to support this. But the other challenges exist in like the competing models of insurance. This is to say that when a physician who works at an Indian Health Service facility provides care to a patient through the Indian Health Service payment model, they're compensated like 100%. However, in a patient who's eligible for Medicare or Medicaid can also access care through this coverage, and similarly, the physician will be paid the same amount. The argument is if somebody is accessing care through the IHS model, then they should have a greater chance of being reimbursed than that Medicare Medicaid provider to keep the care all within the system. It's kind of an evolving challenge presently, and one that still has a lot of kinks to be worked out at both federal, state, and local levels, and is surely becoming more and more complicated. But as I say, there's still a lot of work to be done in terms of how we guarantee care for all of these individuals.
Indeed, sounds like there's, we have a lot of work to be done all around. I think one of the things that I was really excited about this panel is to hear a lot of the great work, though, that these individuals have already started to undertake to fill some of the gaps. And I was really uplifted thinking about this panel and thinking about the great work that many of them have undertaken in their state. I did want to end, and I'm going to turn it to Dr. Subramanian as our Conquering CHD leader here, to talk about how you see us moving forward. I know you talked about your tiered system idea that many people have advocated similar to you, talking about ways in which both surgeons and pediatric cardiologists and others can think about that in a way to work together to move forward on this for prenatally diagnosed, postnatally diagnosed adults with congenital heart disease. How do we see this as a big picture?
Yeah, excellent question. So this is going to take a lot to move the needle. So what I suggest we do is we start with low-hanging fruits, that is areas where there are major gaps that we need to fill. You beautifully mentioned at least two of the things that I had in my mind: adult congenital care and the care of this so-called, prenatally diagnosed. How do families prepare for this news and this lifelong care? And then we can graduate to a little bit more difficult decisions like immediate postnatal urgent care or emergent care. So what I would think we as a group should do is identify these areas of big gap and see what the reasons for the big gap are. The panel here has beautifully identified some of the areas. One may be distance to travel. Two, maybe health literacy. Three, maybe availability of providers. 4, maybe availability of expert providers. So if we identify these 4 or 5 areas, we go to the nearest large center that there is, try and partner with them and see what do we need to do next. Do you need to hire one more adult congenital cardiologist? Do you need to put a cardiologist that's close by, like Dr. Pavandi was saying? Should we put somebody in Central California? Should we put somebody close to the Oregon border? How do we bridge these gaps to bring people together? My opinion would be that's where we start. And the second, and I'll finish there, advocacy. This needs to happen at a federal level. People need to recognize that the #1 birth defect requires #1 level of attention. Otherwise, it's going to take forever and we won't move anywhere.
Well, thank you all. I really appreciate this. I think this was a really robust and lively discussion. We're going to turn it back over to Rebecca, and Rebecca, let you lead us forward.
Thank you so much, everyone. We are going to take a 10-minute break, and we will return with the final session